came across a really alarming statistic recently that apparently a woman dying by suicide typically happens between the ages of 45 and 55. There's quite significant alarming numbers during that time. And interestingly, so women might present as depressed, but during that time, there is also this kind of chemical hormonal storm that's occurring that as mental health clinicians, I think we neglect to take that into consideration in terms of how we work with women within that age bracket. This is a very special 7-minute schemas. My name is Rita. I'm a clinical psychologist and an advanced schema therapist supervisor trainer. And here in the 7-minute schemas, we are talking about perimenopause.
Yes, I'm excited, Rita, to have this conversation today. I'm also a schema therapist, supervisor, trainer. And I think, being women around that age, we have some lived experience of kind of working out what is going on here. So I'm so glad that we've got Dr. Nadia Boscaglia here, who's going to really help us understand what it is that we need to know when it comes to perimenopause. So welcome, Nadia.
Thank you so much for having me, Rita and Ruth. I too am a clinical psychologist. I have had a long history and interest in women's reproductive health and their mental well-being and functioning. And about maybe a bit more years ago, I really developed an interest in perimenopause. So before we really get into it, let's just get our terms right. So we've all heard of the perimenopause, and then there is the menopause. So what's the difference between the two? The menopause is one day of your life or of a woman's life, 365 days after a woman's last period. The perimenopause is the period leading up to that, and women can be symptomatic for 4 up to 10 years before their menopause. And in this country, our average age of menopause is 51.
And it might be worth talking about some of those symptoms, because I think what's really important is that some of those symptoms closely relate to someone presenting with classic depression or classic anxiety, some of the symptoms that you might hear. So you've got a 45 plus woman walks into your office and she's complaining of sleep disturbance, mood changes, irritability, appetite disturbance, and just not getting enjoyment out of things that she used to enjoy, and feeling overwhelmed and distressed. And this woman might go to a GP and she might get prescribed antidepressants. And as a psychologist, I might treat her with just kind of classic CBT or something to that effect, which is the gold standard for someone who presents with depression. But I'm missing something really important, aren't I, Nadia?
Yes, you could be. And Rita, I would say not just a 45 plus, but maybe even a 40 plus woman walks into your office with those symptoms. And in particular, be on the listen out for a few more symptoms. So perimenopausal depression has a few slight variations from our more garden variety major depressive episode. So what you may see is a paranoid flavor. Now, not in a psychosis sort of way, but in a self-deprecating sort of way. So the classic might be, I don't think they do, but I just feel like everyone in my office hates me. They're all talking about me the minute that I leave. So there might be this flavor of paranoia. Rage is a big one. So, I was never a 0 to 10 person, and now the kids drop something on the floor and I'm losing my marbles. And the third one that is worth a listen is forgetfulness, concentration. So those 3 factors, the rage, the paranoia, non-psychotic flavor paranoia, oh, there you go. Which one did I just say first? There's some forgetfulness.
Memory lapses, Nadia.
Memory lapses.
There we have Exhibit A.
Thank you. The memory lapses, the rage, and the paranoia are often more prominent. And in actually one of our main menopause or perimenopause depression scales put together by our own Melbourne sort of leader in women's mental health, who's Jayashri Kulkarni, who's a psychiatrist. the MAPrc scale, which is free. Just Google MAPrc. They also include joint aches and pains is also another common feature.
So it's one of the challenges though, Nadia, isn't it? Because you might be getting some of those sort of indicators, perhaps there's some perimenopausal things going on, and therefore you might say, have you talked to your GP? Well, you know, they might maybe give a blood test, and the person says, well, no, they did the blood test and I kind of apparently I'm not anywhere near menopause. Can you explain that to us?
Absolutely. So ideally, well, not ideally, in reality, menopause is not diagnosed by a blood test, and menopause, a good diagnosis of someone being in the perimenopause is done by clinical interview and by symptoms. And if I can just briefly show you a diagram, which is one of my favorite diagrams. Here we've got a premenopausal woman, and that is 6 months of her life. And you can see this beautiful rhythmic rise and fall of our hormones. Then we've got a perimenopausal woman, and you can see this unpredictable, erratic storm of estrogen, progesterone, follicle stimulating hormone, and luteinizing hormone. And it's all over the place. So if a woman goes to her GP, and if we can see that solid green peaking line, if a woman goes to her GP and has a blood test on that particular day, she'll look like her estrogen's fine. She's nowhere near menopause. So blood tests can be really misleading. In the postmenopause, it's much clearer and much simpler. And actually, a lot of the mental health symptoms tend to settle postmenopausally. So that diagram is a great illustration of why a blood test to diagnose perimenopause isn't useful at all.
And it's that diagram in the middle that helps us understand some of those symptoms that you were describing earlier. It's really interesting that hormones play such a significant role in our mental health and well-being. Who would have thought?
Well,
absolutely.
Before Nadia, you get into that answer, our 7 minutes is up, but I think we deserve more than 7 minutes. So why don't we come back to part 2 and hear how you can help us to unpick some of these issues, and as clinicians and women get the help that we need and deserve.